So thank you very much. I'm really happy to be here, happy to be talking with you about my favorite topic, which is genetic diagnostic techniques. And I really want to not focus on the technicalities of genetic testing. I think that can get boring pretty quickly, but what's really exciting and really interesting is the way that new genetic technologies have changed the philosophy and the approach to the diagnostic process. So that's really going to be the theme of my talk today. And I'm going to start with a case. This is a patient that I care for. This is not her brain imaging, but it's representative of her brain MRI. So she'd had a few symptoms as a teenager, including ptosis or drooping of the eyelids, and also some difficulty moving the eyes, which are symptoms that I'm sure a lot of you will recognize. But other than that, she didn't really have any complaints. She had 2 healthy pregnancies, a couple young kids at home, and then during her 3rd pregnancy, she had some acute neurologic symptoms. So she had some numbness and some weakness, and because of that, a brain MRI was obtained. It didn't show that she had had a stroke, but it did show this finding, which is called leukodystrophy. So the area in the middle of the brain MRI is abnormally bright, and that's what's called the white matter of the brain. And there's a specific diagnostic thought process that you would go through in an individual of a particular age with leukodystrophy. So her providers did that. They got a lot of different tests. They checked for autoimmune diseases and infectious diseases, checked for some metabolic and genetic diseases, but they weren't able to make a specific diagnosis. She was seen both by local providers as well as national referral centers, still without a diagnosis. But luckily she did go to a provider who was pretty experienced with getting whole exome sequencing, and that provider sequenced both my patient as well as her parents and found that she had 2 mutations in a gene called TYMP, or thymidine phosphorylase. That's a gene that causes a condition called mitochondrial neurogastrointestinal encephalomyopathy, or MINGI. And the important thing about making that diagnosis is that there's very specific treatment associated with it. So both bone marrow transplantation and liver transplantation have been shown to alter the course of this disease. So this is a patient who was not fitting the script for how this condition presents. She had an atypical presentation. Because of that, no one was able to make that diagnosis based on targeted testing, and it was only with an untargeted testing approach that they found the correct diagnosis and were able to implement treatment for her. So I want to talk about what the traditional approach is, and then we'll talk about some of the problems with the traditional approach to diagnostic testing. So the traditional approach is that you have to get a bullseye, right? So if you're sending targeted testing, you have to know exactly what you're testing for, and you have to hit that diagnosis. So that involves doing really extensive characterization of the patient. That might include imaging, like the brain MRI that I just showed you, CT, ultrasound. It also might include blood tests, looking for infectious conditions, autoimmune conditions, metabolic conditions, sending round after round after round of blood tests. It might involve things that are more invasive than that. So it could involve muscle biopsies. In an adult, a muscle biopsy might be a needle biopsy procedure. In a child, that might be a sedated surgery, which is a big deal. And it also might involve just waiting. So for every disease, there's a first symptom, and the first symptom is usually pretty nonspecific. And it's only over time that multiple symptoms start to come together to form a characteristic clinical syndrome that you can accurately diagnose with a targeted test. So if we want to diagnose people sooner, we're going to have to be able to diagnose them when their symptoms are more nonspecific. And that makes it hard to do targeted testing. In the past, we had patients who would get testing fatigue. So they would come back year after year after year after year, and we would send new targeted tests and new targeted tests, and we would always have negative results. And after a while, they gave up. because they were tired of round after round after round of testing. So this paradigm has really changed. So I'm going to take one more slide to talk about the problems with that traditional approach, and then I'll talk about where we've moved in terms of a diagnostic thought process. So I have a picture of a street light here to remind me to tell the parable about the person who's coming home from dinner, you see someone on the sidewalk. They're on their hands and knees under a street light, and you want to help out, so you ask them, you say, "Hey, can I help you? What are you doing?" And they say, "I'm looking for my keys." And they say, "Oh, well, let me help you. Where did you drop your keys?" And they say, "Well, I dropped my keys across the street." And you say, "Well, why are you looking here?" And they say, "Because here's where the light is," right? So that's the paradigm that we've had in the past. We've been looking where the light is. We've been looking for the diseases that we know how to accurately diagnose clinically, and the diseases that we have targeted tests for. There's a lot of conditions that we don't have targeted tests for, and there's a lot of conditions that present in unusual ways. So a lot of clinical syndromes that look pretty identical can actually result from a lot of different diseases, not just different mitochondrial diseases, but different non-mitochondrial diseases. So Dr. Shamima Rahman, who practices in London, spoke yesterday, and her presentation really struck home to me. So she had a series of case vignettes, and she had the audience vote on whether this is the foremost group of mitochondrial experts in the world, so she had people vote on whether these patients had mitochondrial diseases or not. And we were all wrong, often. So she presented patients that had things like peroxisomal diseases, disorders of glycosylation. So while there are some mitochondrial diseases that have very characteristic clinical presentations, things that we can recognize and identify, there are other mitochondrial conditions that have a lot of overlap with non-mitochondrial diseases. So it's very difficult to accurately diagnose patients, unless you get lucky, if you're in a scenario where there's a lot of overlap between different types of conditions. What if a patient has an atypical presentation for a disease? So my patient, who I told you about initially with Mingy, didn't have the typical presentation of that disease, and that's why it was missed. She was older than your average patient. She didn't have some of the characteristic features of the condition, and as a result, the diagnosis was missed. This is really important. So what if you don't have access to an experienced specialist with personal experience in mitochondrial disease? Mitochondrial diseases are rare. People who have experience with multiple patients with mitochondrial disease are even rarer. So the odds that any one individual is going to be initially seen by a provider with the relevant experience is pretty small. So if we can move from a paradigm of needing to have extensive expertise and personal experience to a paradigm where broad testing can make a diagnosis, then a lot of patients who don't have access to specialists are going to get accurate diagnoses. What if a genetic disease is only recently described? So there are over 300 different genetic mitochondrial diseases that we know about right now, and that number is increasing rapidly each year. There may be up to 1,000 or even more different genetic mitochondrial diseases. I see a pretty high volume of individuals with mitochondrial disease, but I've only seen a couple dozen of the different genetic mitochondrial disease, let alone the hundreds that are out there. So even for someone who considers this to be a specialty, it's pretty unlikely that I've seen the specific mitochondrial disease that I need to know about to accurately clinically diagnose the patient. What if two different diseases occur in the same patient? This happens more often than you would think. So our data from broad testing show us that 7% of patients have two separate, completely independent genetic diseases simultaneously. And it's incredible. I mean, it just boggles the mind how difficult that would be to make those diagnoses clinically, right? It's only in the setting of broad and untargeted testing that we're even able to make two independent diagnoses. So how have we gotten to the point where broad genetic testing is even a possibility? This is a slide that you may have seen before. So I want to draw your attention to a couple things. This is a logarithmic scale. So each of the horizontal lines is a 10-fold reduction in the cost of genetic testing. And at the far left is 2001, when it cost $100 million to send, to sequence the genome. By 2008, we were, or maybe by 2005, the x-axis is cut off for me, but let's say 2005, we were down to $10 million, and then $1 million, and then a 10-fold drop to about this point, $10,000 for a whole genome sequence. That was around 2012. So that was when it started to become even a possibility for us to do this kind of really broad testing for our patients. So I remember, I think it was in 2013, I sent my first whole exome sequence for a patient. It was a really big deal. We had to get approval from multiple people in the hospital. Insurance wouldn't cover it. The lab agreed to do it in this special scenario. We had to move heaven and earth to get this test done. And now we do it a couple hundred times a year. So the paradigm has changed really quickly. So down here in the lower right corner, this is where we are now at about $1,000 for the sequencing cost of whole genome sequencing. I want to emphasize that's not the total cost of whole genome sequencing. So there's a lot of cost associated with the analysis of the test, maintaining the infrastructure to be able to do that test. So there are, in some cases, we can do whole exome sequencing for about $1,000 clinically. Typically it ends up more like $3,000, $4,000. Whole genome sequencing might come in at like $6,000. So it's I don't want to make light of the cost associated with this. So there's still very significant cost associated with broad genetic testing, but it has come down to the point where it's comparable with a lot of other tests that we do. So a brain MRI might be on the order of $1,000. So we're starting to get parity with some other types of diagnostic modalities. So I want to tell you about some terms that you'll hear both elsewhere in the meeting and in my talk today. So sequencing is the idea of assessing the genetic material at maximum resolution. So the sequence, that's the letters of a gene, that's the maximum resolution that we can get to. Deletion analysis is a lower resolution test. In the past, we had to use completely different tests to be able to assess for deletions in the genetic material as for changes in the sequence. And increasingly, those are included within a single test. So one of the trends in recent years has been to be able to encompass more and more different types of genetic variation within a single test. So you're taking more and more of the need for decision-making about which test to send. That's becoming less and less important, and it's becoming more and more important how you analyze that information. I've mentioned both exome and genome. Those may be terms that you've heard before, or maybe not. When I say whole genome sequencing, that means you're looking at all of the genetic material. So that's 3 billion letters that you're spelling out. Whole exome means to look at the portions of that genetic material that make proteins. So that's a little over 1% of the genetic material actually encodes the substance of proteins. And the rest of it is regulating those genes. The advantage of doing whole genome sequencing is that it's comprehensive. So you're covering all of the genetic material. You're not introducing any bias into the process by trying to pull out particular parts of the genetic material to look at. The disadvantage is that it's more expensive. You're doing a lot more sequencing. It's 100 times more sequence that you're looking at. But you can detect types of genetic variation with whole genome sequencing that you can't find with whole exome sequencing. So increasingly, as the cost of sequencing comes down, you're going to start to see the typical broad genetic test moving from whole exome to whole genome. Practically speaking, right now, it's mostly going to be whole exome sequencing that you'll see. I've drawn this distinction of targeted testing from broad testing. I want to emphasize that this is not a black or white question. So it's a spectrum going from less targeted to more targeted. So sometimes you might see a provider use a panel approach where they're testing all of the known mitochondrial disease genes. That's a really reasonable approach sometimes. So for each clinical scenario, you can make a case for a more targeted or a less targeted approach. The point that I'm making here is just that over time, we're consistently moving in the direction of broader and less targeted testing. Mitochondrial DNA, or mtDNA, has some very different characteristics from the rest of the genes. So of the patients in our mitochondrial clinic, about half of them have mutations that are in mitochondrial DNA, and about half have mutations that are in nuclear DNA. So the different characteristics of the mitochondrial DNA mean that you need to approach genetic testing differently. The big difference is that for mitochondrial DNA, you have several thousand copies in each cell, as opposed to just 2 copies of nuclear DNA. So for a nuclear gene mutation, if you look at the genetic sequence that's coming out of your machine, you either have 0%, 50%, or 100% that's affected. There's only 3 options. For mitochondrial DNA, you could have 2%, or 18%, or 37%, or 82%. And that percentage has clinical significance. That's called heteroplasmy. So because of that, you have to use different techniques to look at the mitochondrial DNA. Although the lab that I work with most on whole genome sequencing is really rapidly improving their capability to make calls about mitochondrial DNA variants and about the heteroplasmy of those variants from their single big test. Their whole genome sequence now includes mitochondrial DNA. I do want to point out this idea of mosaicism. So this is particularly relevant for mitochondrial DNA. Mosaicism is the idea that the whole body, not all the cells in the body, have the same genetic makeup. So for mitochondrial DNA, this is particularly relevant for individuals that have a deletion in mitochondrial DNA. A deletion in mitochondrial DNA is pretty quickly removed from blood cells. So an individual with a deletion in mitochondrial DNA, if you test their blood cells for that deletion, you won't see anything at all. If you were to do a muscle biopsy and test it, then you would see that deletion. So that's the idea of mosaicism. Different cells in the body have different genetic makeup. I may have mentioned these words so far, genotype and phenotype. These are somewhat technical terms, but they're important for the point that I'm trying to make, which is that there's a time for figuring out the genetic makeup of a patient, and there's a time for getting more information about the clinical characteristics of a patient. So phenotyping is getting information about the clinical status of a patient. Genotyping is getting information about their genetics. And I'll come back to that idea. The last term that I want to point out is the idea of functional testing. So functional testing is getting information about how the cells or how the body is working in light of a particular genetic variant that's present. So we all have rare genetic variation. It's important to be able to sort out the genetic variation that is potentially disease-causing from the rare genetic variation that doesn't have any impact on the function of your body. So in that scenario, we go to functional testing. So we might do things like looking at the activity of an enzyme or looking at the level of a metabolite in cells. Sometimes we can do that in blood. Sometimes we need skin cells to do that. A lot of the talks at the meeting have been about how to do this functional testing in the least invasive way possible. What are the things that we can do in skin cells that we used to have to do in muscle cells? So I want to dive a little deeper into the characteristics of testing for mitochondrial DNA. When I was talking about whole genome sequencing, you might you might look at any point in the DNA maybe 50 or 100 times. And if you look at any point 50 to 100 times, that's enough to know whether you have 0% or 50% or 100% of a mutation at any particular position. 50 or 100 times is not enough to reliably distinguish whether you have 10% or 32% or 45% of a 3243 mutation. So in order to accurately calculate heteroplasmy, we need to do what's called deep sequencing. So we would look at any point in the mitochondrial DNA maybe 3,000 or 4,000 times, and if you do the sequencing enough, if you get that depth, then you can start to accurately comment on what the heteroplasmy is. The deep sequencing allows us to accurately identify if someone has, say, 2 or 3% of their cells impacted, or 2 or 3% of their copies of mitochondrial DNA impacted by a particular mutation. And the significance of that is that in the past, we had to do a lot more muscle biopsies for the purpose of mitochondrial DNA sequencing. That's less important now that we can do deep sequencing. So we can check cheek cells, we can check urine, we can check blood cells, and a lot of times we can find the mutation that is diagnostic for the patient because of this deep sequencing. We can find that mutation in less invasive tissues. Other aspects of mitochondrial DNA that are different, as I mentioned, we may need to test multiple tissues. It's pretty rare that we need to do that in the case of nuclear DNA. And in the case of mitochondrial DNA, we're usually testing more family members than we are with nuclear DNA. So for nuclear DNA, typically we'll try to test both parents, both biological parents, as well as the affected individual. For mitochondrial DNA, we often end up testing a dozen or more family members and finding that different people have different symptoms related to the degree of heteroplasmy they have in mitochondrial DNA. So all of these technological improvements are bringing me to the main point that I'm making, which is that the idea of when to phenotype and when to genotype, so when to get more information from imaging and blood tests, and when to do genetic testing, has flipped in recent years, I would argue. So rather than exhaustively gathering information over the course of many years and waiting for a condition to evolve before we finally send that one targeted genetic test, we've flipped the approach, and really we just need enough information about a patient to determine what is the degree of suspicion for any genetic condition at all. Once you have, and there's no right answer to how high that suspicion needs to be, right? So you can make an argument that if there's a 5% chance of a genetic condition, it's appropriate to send genetic testing. Other people would say that your threshold should be higher. There's not a right answer to that question. The other thing that we need to do at the outset is to document the data that's needed for interpretation of genetic results. So I've made the point that we all have rare genetic variation. I've looked at my own whole exome sequence. It can be pretty scary. You have rare variants throughout the genome that look like they might cause disease. So it's very important that you have enough information to be able to interpret what those rare variants mean, because they're not all meaningful. My approach, and the approach of my colleagues now, is to do genetic testing much, much earlier than we used to, often as the first diagnostic test that we send if we have adequate suspicion of a genetic mitochondrial condition. And then we allow those genetic results to guide us in terms of what type of functional testing and what type of phenotyping we do for the patient. So rather than getting organic acids and amino acids and a nasal carnitine profile and a lactate and a GDF-15 and a muscle biopsy to look at under the microscope and a brain MRI, and you add all that up and we say, maybe it's MELAS, maybe it's Kern-Serre, I don't know. We would do the genetic testing first if we have adequate suspicion, and then in a more targeted way, we would do those functional tests that would give us a yes or no answer about any particular genetic result in terms of whether it's significant for our patient. I do want to mention pharmacogenomics or pharmacogenetics. So this is something that a lot of you may have heard of. Depending on the lab that we send our broad genetic testing to, some of them will give us pharmacogenetic information. In other cases, you need to obtain that as a separate test. The pharmacogenetic variation is looking at something different than the whole genome sequencing and the mitochondrial sequencing that I was mentioning. The whole genome sequencing is really looking for very, very rare genetic changes, things that are either not present at all in the general population or present at very, very low levels. Pharmacogenetics, you're looking for common genetic variation, so things that might be present in 1% or 10% or 20% of people that impact how you absorb and metabolize and excrete drugs. And there are certain drugs that we have very good information about how the underlying genetic variation within the individual that's being treated impacts how they respond to that drug. So there's a drug called azathioprine, which is an immunomodulator that can have very, very, very different effects depending on the level of an enzyme that someone has called TPMT. So at least at my hospital, it's considered standard of care to test for TPMT prior to using this drug, azathioprine, because people have such different responses depending on their underlying genetics. And there are varying degrees of evidence that we have about different pharmacogenetic variants, but for a couple $100, you can get a readout of the known variants that you have that impact commonly used drugs. And more and more providers that prescribe drugs are using that information to guide them in terms of what doses they should use and what drugs they should avoid entirely. There are some health systems that have started to integrate this information into the medical record. So if someone has had a pharmacogenetic test, then that information is in the medical record. If a physician goes to prescribe a drug that should be a different dose based on the genetic variation in the individual, there's an advisory that pops up and tells the provider to change their dose. This is a step towards what we call personalized or precision medicine. So the idea that each individual has specific aspects about them that mean that they should be treated somewhat differently from all other people. This is a small step in that direction, but you can kind of see where this is going. So where are we headed in terms of genetic testing? The sequencing is getting faster and faster. So the fastest whole genome sequence was done in about 20 hours. So I remember I told you back in 2013 when I first sent this test, and it was a really, really big deal to send it. It took about 6 months to get results. So in 6 years, we've gone from 6 months to as fast as 1 day. Now, we don't usually get 1 day turnaround on this test. So on an outpatient basis, it's still a few months, a couple months to get results back. But in select cases when we have really ill patients in the ICU and we suspect a genetic diagnosis, we will send rapid whole genome sequencing with turnaround in a couple days. The other thing is this is getting cheaper and cheaper. So this is getting more broadly available. There are genetic tests that are cheap enough and available enough that providers outside of genetics are starting to be more and more comfortable using them. So neurologists, gastroenterologists, other providers are starting to send more and more genetic testing. One technology that is advancing is something called long reads. So the genetic testing that we do right now is really, really good at detecting the sequence, but it's not very good at detecting larger scale genetic variation. And this, what's called long read technology, is going to be able to figure out chromosomal rearrangements and things like that. The other thing that we're going to be doing increasingly is integrating the genetic sequence that we have with other information about the patient to provide a unified interpretation of what that means. So the translator between DNA and protein is called RNA, and increasingly we have the ability to look at RNA. We have the ability to look at all the proteins. That's something called proteomics. Metabolomics is then one step down from that, looking at the different metabolites in the body. And then the last step is what's called deep phenotyping. So I was at a conference recently where there was a data scientist who has created an algorithm that just runs in the background of the electronic medical record and looks for characteristic signs of particular diseases, and then provides a notification to providers when there's enough suspicion just within the medical record of a particular condition being present to advise the provider to consider testing for that condition. So that's an idea called deep phenotyping. And that integrates all the way up the line with the metabolites, with the proteins, with the RNA, with the DNA to hopefully provide a unifying diagnosis. We increasingly are using genetic testing with newborn screening. So there are research studies where broad testing is done as a newborn screen test. Right now, it's mainly targeted testing. So the genetic testing that's part of newborn screening is usually a follow-up to an identified metabolic abnormality in the newborn screen. This, again, is one that there's not a right answer to. So there's a healthy debate going on about how much genetic testing should be part of newborn screening. And that's an ongoing debate, and appropriately so. But as the testing gets cheaper and cheaper and more available, the opportunity will arise for that to play a part in newborn screening. So I hope that I have been able to convey to you the fact that we're really in a different era of the approach to diagnostics. Based on the technological improvements in genetic testing, we're in an era where the genetic testing can move much closer to the beginning of a diagnostic workup, and that genetic testing can be used to guide the rest of the diagnostic workup as opposed to the other way around. So this has really been a big paradigm shift for myself and my colleagues, and I'm happy to talk with any of you all about specific questions or ideas that you have around this.
My question is it reasonable to assume, with everything that you know now, that genetic testing may not need to be done in the case of, like, if your kids all have mito, they've all been identified as having mito, is it necessary to test the mother or the grandmother for symptoms that they're having, or just go to a treatment model? Which one is more assumed with everything you guys know now?
I would say it entirely depends on the specific scenario. So there are some cases where I feel confident enough about the presence of a diagnosis that genetic confirmation of that maybe isn't necessary. If someone has all of the characteristic features of a condition and a family history of it, that may be adequate to pursue a treatment strategy. I will say that we're more and more moving into this idea of probabilistic thinking. So nothing's black and white, right? So we may be certain enough of a diagnosis to pursue a watchful waiting strategy, maybe annual screening test, something like that. But for the first case that I presented, the intervention for that patient was a liver transplant. So you need to be 100% sure of a diagnosis if you're going to do a liver transplant. So we did genetic testing, we did enzymatic testing, we did biochemical testing. We made sure that we were sure in as many ways as we possibly could be before we implemented such a significant intervention. So it depends on the scenario.
Because
Yeah.
it's hard to find you guys, because
Yeah.
you guys are so rare to find. And I'm putting all my energy into my children. All my children have, my daughter has 2 variances, my sons have 1 variance. And unless I'm not their mother, I don't know what else to say. And because it's difficult to get all the testing for myself and my mother, because you can't find anyone to do it on the adults where I live. I take my children to Goldstein in Philly, and I don't have time for me, but I have symptoms. I have issues. So trying to treat those.
Yeah, and so what I talked about is a little bit of the present, but it's also into the future, right? So I recognize that genetic testing is not available for everyone, but I think it will be. I think that's the direction that diagnostic evaluations are going in. So my hope is that genetic testing would be more available if it seems like that's appropriate for your case.
So I also have a similar question, but it's the opposite. So I have 3243 is greater than G. My older sister was tested and came up with less than 15% and just diagnosed as not having it. Should I have other family members tested? And then the other question with that is, with the political climate and the change of pre-existing conditions, I'm being told not to test my children if they are not needing insurance to pay for.
So you bring up a great point. So there's a law called GINA, which was passed in 2009. So it's called the Genetic Information Non-Discrimination Act. That prevents health insurance from using genetic information to make determinations for coverage. It also prevents employers from asking for genetic information. The exceptions on the employers are for companies that have fewer than 15 employees in the military. So both of those entities are allowed to ask about genetic results, and they're not breaking the law. Life insurance, long-term disability insurance, those entities are allowed to ask if you've ever had genetic testing. So if you are considering getting a life insurance policy, then it's it may be worth waiting on genetic testing. I would be a little surprised if that law got changed, but it's certainly possible, and taking that into account is a very reasonable consideration in terms of thinking about whether or not genetic testing is right for you.
Okay, I had genome testing done in 2011, but they couldn't find, I was tested positive, but they couldn't find exactly what it was. And, but I'm thinking, I've been wondering about having something done again. So I haven't sat back down with that doctor to get specifics, because my treating doctor was supposed to, who hasn't, because he doesn't know enough. So I don't have all the specifics of all my testing. I have all the results, but I don't have answers. So I'm not sure really what to do. It's been a while, 8 years, So I really don't know what to do. I know there's new things, new steps, stuff like that. I want more details because I really would like to know where I'm going to go in the future.
So a couple thoughts for you. Genetic testing is very, very different in 2019 than 2011. So my typical approach is that even if I've already sent whole exome sequencing on a patient, but I feel compelled that there is a genetic diagnosis that's likely to be found, I'll repeat that test if it's been at least 3 or 4 years. So that's kind of the time frame that I think about in terms of the test having improved enough to repeat it.
You touched on something that I've been meaning to ask another one and didn't. It's the first time I've heard it, and it's something I think is relevant to a lot of people. You said in Malays, at least, the first one you did, that the liver transplant actually affected how the disease progressed or reversed it. And we had a situation with my son who had a small bowel transplant because there was no other way. And there wasn't proof at the time that it would do it, but it has. done that. Now, can you explain a little bit about how that transplant situation worked? And there's a lot of people that have small bowel issues that are on TPN that we don't know why it worked, but it worked for us in that way. Can you give us a little more information?
So that is a very specific scenario. So that's a condition called MINGI, mitochondrial neurogastrointestinal encephalomyopathy. MINGI is different from most other mitochondrial diseases because it's an enzyme deficiency. And if that enzyme is deficient, then there's an accumulation of something called thymidine. And thymidine is basically poisoning all the mitochondrial DNA. So if you restore the enzyme activity, either from a bone marrow transplant or a liver transplant, then the thymidine goes down to normal and it stops causing secondary mitochondrial mutations as a result. What I mentioned is entirely specific to MINGI, and it's only for people that have elevated thymidine. So if there's elevated thymidine, low thymidine phosphorylase activity, and genetic results that are commensurate with that, that's the scenario for that. The hope is that in the relatively near future there would be enzyme replacement and or gene therapy that would eliminate the need for transplantation for those patients.
I have a question that's kind of been answered, but my son and I were diagnosed it's been almost 10 years ago with a muscle biopsy, and at that time we were just told where our defect was, but we didn't have the catchy name to go with it. Unfortunately, my niece was diagnosed just this past week with mitochondrial disease, and she was told she had Kern-Sayre syndrome and Pearson syndrome. I had sent her doctor all of my data, and they identified that she had the exact same defect as I did.
Mm-hmm.
Is that possible to have a family that
Yes.
they would
Yeah.
in the generation?
Yeah, so you bring up some really insightful points. So there's a difference between a clinical syndrome and a genetic cause for that syndrome. There's a lot of overlap. So, for example, most of the people who have MELAS syndrome have a 3243 mutation, but not all of them. Likewise, some people that have a 3243 mutation have MELAS, but not all of them. So it's in both directions, there's not complete concordance between a genetic diagnosis and a clinical diagnosis. For families that have mitochondrial DNA mutations, the heteroplasmy, that percentage of the mitochondrial DNA that's affected, can dramatically change what the presentation is for different individuals. So Kern-Sayre or Pearson is a clinical descriptor. So that term was coined prior to ever knowing the genetic cause of the condition. It describes a constellation of features. Most people that have Kern-Sayre syndrome have a deletion of mitochondrial DNA, but not all of them. So again, you're seeing that kind of, there's some overlap between the genetic diagnosis and the clinical diagnosis, but it's not perfect. And different people with the same genetic diagnosis can have different clinical syndromes.
Would there be any advantage at this point in my age to have a repeat of either a muscle biopsy or repeat of the sequencing?
So it sounds to me, from what you've described, like there's a definitive genetic diagnosis in your family. I can't speak to your case in particular, but more generally speaking, I usually don't find that there's a lot of utility in repeating that test once there's a specific genetic diagnosis made.
Thank you.
You talked about the difficulty in finding, in a lot of areas, finding doctors familiar with mitochondrial diseases. What advice would you have for someone whose child is transitioning now from the pediatric system to the adult system? My daughter was diagnosed with an unknown mitochondrial disease at 3 months. It was confirmed to be pyruvate dehydrogenase disorder with a mitochondrial DNA screen at 21, and we're now transitioning into the adult world, and in some cases finding it difficult to find specialists.
So that's a really good question. It's a very difficult issue that's an issue most places in the country. There are people who are working on that. Just to kind of give you an example from my hospital of something that you might look into. There's something at our hospital called Special Care Clinic. So Special Care Clinic is meant to be a medical home for kids with significant medical needs. They provide what's called a transition consultation. So they, based on the needs of the specific child, they will identify adult providers to refer to help a child more seamlessly move out of the pediatric system into the adult system. So I would say, I would mention to your primary care doctor that you're interested in that, like a transition consultation, to see if there's an entity like the Special Care Clinic that might provide that service.
Thanks so much. I was wondering, under what circumstances is RNA sequencing important in helping you get to a clear diagnosis?
That's a great question. I can really nerd out about this. So the RNA is different from the DNA because the DNA is the same in every tissue. The RNA is tissue dependent. So there's only certain genes that are used in certain tissues. So what you find from RNA sequencing depends on the tissue that you're looking at. So it's different in blood, it's different in muscle, different in liver. Typically, from my vantage point, and the answers are very different depending on what specialty you're in, but for me, as someone trying to make genetic diagnoses, the RNA, if the RNA is missing for a particular gene, and we know it should be there, or if the RNA is abnormal for a particular gene, that can clue us in that we need to look harder for a DNA mutation in a particular location. So this is brand new technology. Like I've just recently started ordering RNA sequencing in a few select cases. I think it's got a lot of potential, but it's really, really early days in terms of how that's going to be used. But that's how I use it for diagnostic testing, is to look for hidden DNA mutations.
So my question is overarching and then specific. So the overarching question I have is, so we've got, if people have these mutations, why are they presenting different clinically? Underneath that is just finding out that my son may have, has some sort of, the researchers won't tell me specifically yet, but has something to do with myotonic dystrophy, a gene, a protein splicer, but he doesn't look like a kid with he's a neurogastro, that kind of thing. He looks more like a me, he's a myotonic dystrophy. So I'm just curious how you go from this to, that makes sense. I'm not sure it did.
Yeah, so there's a lot of answers to your question of why do two people with the same genetic diagnosis have very different clinical presentations. We had an interesting talk a couple days ago in the scientific session about how mitochondrial DNA mutations behave differently depending on what's called haplotype. So haplotype is the common variation, and depending on where your maternal ancestors are from, you'll have a different mitochondrial haplotype. So that's the background. And then on that background of a haplotype, we have rare variants. But those rare variants behave differently depending on what the background is. So that's one answer to your question. Another answer would be that people have each condition is driven more or less by a single mutation, and then there's other genetic contributors to how significant their manifestations are. So an example that's well studied is cystic fibrosis. So people who have cystic fibrosis, have a certain degree of severity based on their cystic fibrosis mutations. But there's been a lot of study into mutations in the immune system that change how people with cystic fibrosis respond to lung infections. So that other genetic variation, it's not the primary driver, but it's a secondary driver of the severity. And I can't remember your second question.
Oh, it's sort of involved with that, with the myotonic dystrophy. It's just, that seemed to come out of left field when they found the genetics. So.
Yeah, I can't comment on that, but yeah.
You talked about the flipped approach and how your colleagues are embracing that. I'm curious how you define colleagues, and what I mean by that is, do you feel like that's being widely accepted and embraced by more than just maybe your hospital? And then my second question is, how do the insurance companies embrace that? Because often they want you to do this, 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 and this before they pay for this, so you're sort of saying...
Yeah, so you make two really good points. My comments were meant to address a trajectory. So there's no doubt that no matter where you are, the genetic testing is becoming broader and moving earlier in the diagnostic evaluation. That's happening at different speeds and to different degrees, not just, at the level of the individual provider, right? Let alone the department or the hospital or the region. So it's widely variable, but this is the direction that things are heading in. Insurance company, it depends on the insurance company. So different insurance companies have different assessments of the current literature. One of my big projects is to develop information about the cost effectiveness of the flipped approach. So how much money do we save? Because that's what insurance companies are interested in, right? How much money can we save by doing a genetic test initially, identifying a condition, and preventing a muscle biopsy, preventing an MRI, preventing years of blood testing, and just showing them a cost-benefit analysis. And that has been done to varying degrees, but as we contribute more and more to that literature, my guess is that it will become fairly compelling, but I don't know for sure. So we'll see.
We're going to need to wrap up soon, so if you have questions, please make them brief and to the point, because we have a full room, and I don't want you to miss lunch, because not eating is not good for people that have mitochondrial.
My question is a follow-up to that trajectory you just talked about. Being so important to diagnose it early on, if you had your crystal ball, when do you see genotype being rolled out? Because you mentioned it would be very beneficial to identify it early on in that broad manner. When do you see that being rolled out for early detection for those who have other siblings or family members that are going to probably benefit from that?
Well, there's kind of two separate questions there. So one question is about sort of what you mentioned in terms of if you have an affected family member, what's the consideration of whether to test additional family members? It's a very personal decision. Some people don't want that genetic information, and that's fine. In terms of the broad application, the broadest possible application is to just do whole genome sequencing as newborn screening, right? We're nowhere near that. You could imagine a scenario in which anyone that gets admitted to anyone who's sick enough to be admitted to the hospital, maybe it's worth doing broad genetic testing. Maybe you start by getting that pharmacogenetic information, but if other specific questions come up during a hospitalization, you can answer those questions to some degree by consulting the genetic information. I don't know, but I think it's interesting. It's interesting to think about what the applications will be.
I was just curious, how much weight is given to the muscle biopsy? You have a negative muscle biopsy.
Negative in what way? Be normal appearing under the microscope. That's one piece of the phenotype, right? So the phenotype is the cumulative information that you have about the clinical status of a patient. So that's one data point that you have to consider it in the whole picture.
Just a follow-up on the muscle biopsy, is genetic testing through blood work compared to genetic testing through muscle? Are they just two different tests, or is the muscle genetic testing better?
It's the same test, but the genetics of the muscle can differ from the genetics of the blood. The testing has gotten more sensitive for blood, so there's less of a difference than there used to be with current technologies. But I would say the scenario in which you would want to do a muscle biopsy in order to do genetic testing would be if you have a very high suspicion for CPEO. So if someone has ptosis and ophthalmoplegia, that's the most common clinical scenario where you would miss the genetic diagnosis by testing blood rather than muscle.
So usually they start with blood and go to muscle.
So I usually start with cheek swabs because you're more likely to catch the mutation in the cheek swab as opposed to the blood. So the cheek swab is not as good as muscle, but it's better than blood if you're looking for that mutation. So that's usually my starting point. Also, almost no one minds having a Q-tip in their cheek. So.
When talking about genetic sequencing with mito or any abnormality, what do you compare the genetic sequencing to, if you do?
Yeah, that's a really insightful question. So the question is, how do you figure out what's a rare genetic variant? And the answer is that we have ongoing improvements in our population database that we compare to. So the database that almost everyone uses is called GNOMAD, GNOMAD. And right now there's about 120,000 people that we're comparing to. So as that gets to 250,000 people, 500,000 people, we continue to get improved information about what's rare, how rare is rare. And then we get improved interpretation of the results based on the improvements in that population database. So that's a great question.
It's a two-part question, if you don't mind.
Sure.
The second one being, is there a database online in a library somewhere where I can enter my gene variant, which is unknown at the moment?
Yes, there are databases for that. So commercial labs will do that. There's something called ClinVar. So ClinVar is the database that labs will enter data into. There's something called Gene Matcher that clinicians will use if there's a specific gene that they feel is a diagnostic finding, but it hasn't been published yet. They might put it in Gene Matcher and get matched up with other clinicians who have the same finding. So yes, there are databases that serve that purpose.
Thank you so much. This was fantastic.